All right, I think we're going to get started. Hello to everybody who's out there on Zoom, and welcome to Pulmonary Grand Rounds. I'm really pleased today to introduce our colleague, Frank Detterbeck, who's going to talk about lung cancer, where we've been and where we're going. And it's a pleasure to introduce him. Frank and I have been working together since 2004. Recruiting Frank, every time he came was a day like today. It was 5 degrees and it was snowing, and he was coming from North Carolina where it was warm. And I was sure he'd never come. But here we are. It's 20 years later, and we were talking just this past weekend about, 20 years goes by when you're having a great time with your colleagues, learning, building, growing programs. So I have Frank's CV, which this is double-sided, 365 peer-reviewed publications, 60 invited editorials, multiple books, like whole books. And it's really the written testament of the kind of surgeon he is. And I met Frank at I think the first lung cancer guidelines writing committee. It was in North Carolina. And there's a big room full of people, most of whom I didn't know. And there was this guy sitting there who I assumed was a pulmonologist because he was articulate, he knew the literature, he was smart and a gentleman. And then I asked somebody, who is that? And so that's Frank Detterbeck. He's one of the thoracic surgeons at UNC. And I was like, are you sure? And I was so impressed. And at that time, we didn't have a section of thoracic surgery here. It was CT surgery. And probably nobody remembers what it was like back then, trying to get great thoracic surgery done when the people who were doing it were predominantly interested in the heart. And so things would happen, like the lung would come out and no lymph nodes would come with it. And it was really hard to be thinking about building a thoracic oncology program, which was the goal at that time, my goal, when I didn't have a surgical partner. And so I approached Frank with some trepidation because he was smart, articulate, looked like an internist, but actually was a surgeon, and asked him, is there somebody at UNC who you've trained as a mid-level surgeon who'd be interested in being the first thoracic surgeon in a new section at Yale? Because there was agreement with surgery that would happen if we recruited such a person. And Frank said, I might be interested in that. And I nearly keeled over and tried to drag him with me onto the plane to come back to New Haven immediately. And the end result is that Frank came in 2004. It was just the two of us. Lynn Wilson, we dragged in from Ray Donkey, really was a lymphoma person. John Murren, who maybe Mark, you remember, was the sole medical oncologist. And Linda David, who was our nurse coordinator. And TOP, as it is today, which is countless numbers of people, huge clinical programs in all the domains, SPORE, Roy Herb SPORE, which is one of 6 in the country sponsored by the NCI, and all the research and education and clinical investigation that has gone on, I think really is a testament to Frank, because he set that tone when he came. And looking at his CV, which is ridiculously impressive, a lot of what's in here reflects team, and that there has been this generous spirit of collaboration, pulling in younger people to work on projects, to write papers, to give presentations, to basically participate and be given a chance. And I think one of the main reasons that the thoracic oncology program here and the thoracic surgery section at Yale have flourished is really his work. And so when Frank came, he was section chief of 1, professor of thoracic surgery, and now there's 7 or 8. Amazing people who are collaborative, generous with time, information, spirit, research. And that is a really different landscape than we knew 20 years ago, when I can tell you that some of the experiences we had with surgery back then weren't like super friendly or collaborative. And so one person can make an incredible amount of difference. And so Frank, thank you for that, because we would never be where we are today without you. But before I give the podium over, you guys know that I like to look at the first publication, somebody's first publication. So this is Frank Detterbeck, first author, when he was actually resident, right? And it is, the title is Recurrent Fever of Unknown Origin with Cimetidine-Induced Nephritis. And so really, Frank, you were actually supposed to be an internist, but you went another way, and we're so lucky that you did.
Well, thanks for the introduction, and it's been a great 20 years to be here, and really enjoyed all the collaboration, and to me, that's what really has made it all work, is that it's a real team effort, and easygoing team, and the team is always better than any one person. So I was asked to give this talk, where we've been and where we're going. That's a pretty broad topic, but I'll try to do my best with that. So let's see, I need to click, I guess maybe I need to click here. Well, I'm not going down there. How do I advance this? I don't know. Do I need to click on the screen? Is that what I need to do? All right, let's just try that. Okay, well, something happened. Okay, so I have no financial conflicts related to this, but I will take the right of an aging dinosaur. But I'm going to try to take a real high perspective, although I'm not sure dinosaurs can do that. So, evolution of treatment modalities. Here's the beginning. First thoracic case, God removing a rib from Adam. But let's move on a little bit to lung cancer, and I don't want to dwell too much on the past, but a couple of things are interesting. So, 1527 described lung cancer. 1851, first case of lung cancer in the US. 1800s, a number of different, pathologic, cytologic, diagnostic things that were happening. And towards the end of that century, X-rays and bronchoscopy, actually, 1897, pretty interesting to me that, it dates back that far. Anesthesia kind of came along a little bit, endotracheal tube with an inflatable cuff in 1895. Although positive pressure ventilation didn't really come in until 1940. I'm not quite sure why there was that delay. And of course, during that period of time, thoracic surgery was difficult because you induced a pneumothorax, and there was, operating in a negative pressure chamber where the lungs were being sucked up, but the surgeon was actually sitting inside the negative pressure chamber. It was all pretty complicated. So things were much more difficult. So that's just to kind of set the, stage of what things were like. So 1933 is often kind of pointed to as kind of the beginning of, surgery for lung cancer. So it was a pneumonectomy. Turns out it was a node positive case, squamous cell carcinoma. 8 rib thoracoplasty. 75-day hospital stay, a little bit different than today, but this was a patient that survived. So that was, and this patient actually never had a recurrence and died 30 years later. And it turns out that Dr. Graham, who was the surgeon, actually died of lung cancer 24 years later. He was also a smoker, and the patient attended Dr. Graham's funeral. So, this was a landmark case, and, this got published, of course, and, lessons learned. Surgery can achieve a cure. That was really not recognized at that time. And disease can be localized, but, it was pretty brutal. And of course, for Dr. Graham as well, don't smoke. So that was then, 2025. Most cases are able to be done minimally invasively with or without a robot or just a video camera. That's really become the standard. We don't send people home that often on the first postoperative day, but sometimes I had a patient go home Wednesday that had a lobe on Tuesday. And there are programs that are actually trying to do outpatient lobectomy, 23-hour stay as a relatively routine thing. We haven't quite gotten to that point. And, clearly it's a better way to do it and less complications, and the long-term outcomes are the same. I'm not going to go through the details of that. Well, actually, I do have some details up here. So, you can see the operative. Do I have a laser pointer? Do I have a mouse pointer? I have a mouse pointer. Okay, so, operative mortality, this is VATS here on the left-hand side and open on the right-hand side. So operative mortality is better. If you look at postoperative complications over here, it's lower with VATS. Hospital stay is shorter, and long-term outcomes are really the same. So there have been advances in other fields as well. So radiotherapy is certainly advanced. IMRT, better contouring of the dose. SBRT kind of accounts for movement, in the chest. Protons accounts for sort of better dose distribution, so you don't get as much dose on the surface, allows you to deliver it better. That's made some differences. That's been an advance. And of course, in systemic therapy, we have lots of different chemotherapy agents now that are, quite effective and have less side effects. We differentiate whether it's an adeno or a squame and small cell, whatever, you get different things. We have targeted therapy based on actionable mutations, immunotherapy, and increasingly it's pretty complex and a pretty rapidly changing field, and smaller and smaller subsets of particular mutations and how we handle that. And there are some novel technologies that are kind of coming around the corner here, endobronchial therapy with ablation through a bronchoscope. I think we have a ways to go before that's prime time, but this is an example from a paper. I would throw out a little bit of a caution, two cautions. I think it's always exciting to have new things. We need to see how well it really works. We need to not ablate things that don't need to be ablated. But the other part that bothers me a little bit is all of the technology around this, because a lot of things that are really heavily based on a lot of technology, they tend to kind of price themselves out of the market to a certain extent. Initially there's a lot of excitement and there's investment, but eventually it becomes a little bit harder to really sustain that. So, that may be a little bit of a limitation, but, we'll have to see where that goes. So, also things have changed over time. So, at one time in an early era, basically there was that green curve, surgery, and surgery, had some role for very limited disease. And, there really wasn't much role for systemic therapy. And, basically we were kind of approaching it like, we had a hammer and everything was a nail. And, it was kind of more of a sledgehammer at that time rather than anything else. And then we kind of went into this other era where we started to see that there was a range of patients where multimodality therapy with systemic therapy plus radiation and or surgery or both, had a role and had a benefit. And there was more role for systemic therapy in late stage disease and so forth. And so we started to have a lot more tools in the toolbox. And where we are now is, I think that really we are talking about multimodality therapy kind of across the spectrum. We're talking about local therapies for oligometastatic disease, oligoprogressive disease, things like that, where we never thought about that before. And we're really moving adjuvant therapy way down into stage 1, where that, also was pretty unheard of. So it's really kind of increase that spectrum. And, certainly over my lifetime, the multimodality has really become the way to go and the way we need to think about it. progress in research. So this trial, the Dillman trial, was a big deal at the time. So New England Journal, 1990, 154 patients. That was like, oh, that's a big lung cancer trial. 1984 to 1987, RT alone versus chemo RT. And you can see the survival curves here, benefit. This was like, oh my God, there actually is hope that we can do something better. People were like, blown out of the water with this. And, in fact, for about 10 years, I would say for about 10 years, you could not go to a conference on lung cancer without hearing about the Dillman trial. We just kept talking about that over and over again because, that's what we had. However, this is kind of the way progress felt. The fact that it took us so long to get to something like the Dillman trial, and then for 10 years later, we were still talking about the Dillman trial, kind of shows you kind of where we were. So here is an overview of perioperative immunotherapy trials, either pre-surgery or adjuvant or sandwich, as it's called, pre and post, and, a number of different trials just in the last 3 years. And this is the way progress feels now. There's just so much coming at you that, it's just, exhausting to try to keep up. And it's just such a change from the way it was years ago. So lung cancer, I think we need to look at it, a little bit differently. I think that this is really kind of a family of diseases. So I'm going to, kind of show you a little bit about that. So first of all, let's just talk about overall lung cancer mortality, number of cancer deaths per 100,000 in the US. This is a CISNET study, and you can see that, it's really gone down a lot in men and in women, and it's projected to go down a lot more. So, let's all keep that in mind. It's going to go down a lot more, and it already has gone down a lot. Now, the CISNET modeling, so this is based on kind of data from an earlier period. You can see how well the model kind of corresponded to the actual results. But it was all based on kind of traditional, association with smoking and current trends and, population mortality and a bunch of, assumptions about what was going to happen in the future. And I'm not completely sure that's right. But certainly we're going to see a decrease, no question about that. So the lung cancer I grew up with was solid, spiculated, often central. See it on the CT scan, on the chest X-ray, associated with smoking, aggressive growth, poor prognosis. Of course, now we're seeing tons of these ground glass opacities that, turn out to be lung cancers, often multifocal. Often the more you look, the more you see. A lot of times never smokers. And the behavior is very different. Why is that? Well, sometimes people say, well, it's due to CT screening. And, certainly we know that, in the yellow here, lung cancer found by symptoms. But if you're doing scans on people, or you're doing scans just because somebody came into the emergency room with a stubbed toe and they get a CT for a PE protocol, you're going to pick up more indolent stuff. So that's pretty clear. So sometimes people say, well, that's why we're picking up these GGOs. But I actually think we need to come up with a more nuanced thinking. I think there are actually a number of different sort of etiologies and types of lung cancer in there that we're not able to sort out quite yet. But we need to figure that out. And I, point a little bit to head and neck cancer where, we're smoking related head and neck cancers. And then all of a sudden there was HPV related head and neck cancers that have different behavior and they respond differently and so forth. And, we think about them as a totally different disease. We haven't quite figured that out with lung cancer, but I think we need to get there. So other things to be aware of. So this is that same CISNET study. And by the way, Yale is one of the CISNET centers, just in case you didn't know that. Um, but if you look at, the dark green is smoking related, current smoking, the light green is people that are former smokers, and the really light green is never smokers. But, here we are in 2025, but, if you look between 2025 and 2050, we're going to double the number of never smokers that have lung cancer. Um, and the number of smokers is going to go down. So that's the case. And that's the case sort of based on the old CISNET assumptions that went into that model, some of which I'm not totally sure they're going to, continue to pan out quite the way they are. So this is one of the reasons why I'm not totally sure. So this was an interesting study done in Korea, and there is a mutational signature, this, S4 signature that, by a whole bunch of different studies has been related to smoking and smoke exposure, and, and everybody kind of accepts, oh yeah, that's the, smoking signature. And they compared the smoking signature with the actual smoking history. And so, if you put these together, you realize that, there are a good number of people that have about 30% here that have a smoking history, but their lung cancer does not have this, smoking related signature, and I do think that we have been sort of blinded a little bit by saying, oh, lung cancer is related to smoking. Yes, that is the major risk factor, but there are other factors, and we have been blaming every lung cancer that comes along on smoking, and I think we're making a mistake. And I think that, realizing this and learning how to look at this differently is going to be helpful for us to start to see some signals that perhaps we're not seeing now. So this was another study, same study that looked at this, S4 group, and, they tended to be older and men and more Europeans, and the others, did include some smokers, as I've shown you, but didn't have that smoking related signature. And they kind of put them into two different groups, so, EGFR positive or other oncogene mutations, or different types of mutations, suggesting that, maybe these were three patterns that we should be looking at. And they suggested, that there were, different etiologies, different, mutations that happened, and different ways that these lung cancers developed, and that we needed to be, looking at them this way. Now, I don't know that this is the way. I think we haven't quite figured it out. Different studies have kind of looked at it a little bit differently. So what about ground glass opacities? I think the simple thing is to say, okay, you've got the solid spiculated lung cancer and you've got the ground glass opacity. Pretty obvious to me that those seem to be different and seem to have different etiologies and so forth. I'm going to show you data that not even every GGO is the same. And we need to be thinking about those differently. So here's a study of patients that had a lung cancer that was resected, and they had additional GGNs. And what happened over time? And you can see that about 2/3 of those, on the bottom, never changed over 10 years. And about 1/3 of them progressed, over time. So kind of evidence that maybe there's two different kinds of GGNs. There are other studies that have looked at GGNs that grew or that didn't grow and looked at mutational signatures. You can see that there's a difference there. They're not the same. You can develop mouse models to study development of AAH. And if you develop a KRAS mouse model for AAH, that doesn't progress. So it's not a good model to study development of cancer. You have to develop an EGFR mutated mouse model to study, progression. So again, another piece of data that suggests that, there's different types of GGNs. They're not all the same. We shouldn't be thinking of them all the same. We need to be thinking about them differently. And this was some of stuff that Kat Powell was involved in, but saying there's, probably for AAH and GGN type of lung cancers that, there are two different pathways there, one of which progresses, one of which doesn't progress. And the traditional lung cancer is probably something completely different, unrelated to those. So number of different studies looking at it different ways, but all of them kind of suggesting the same thing, that, it's not just one disease, it's several different diseases, and we haven't quite figured it out, how to separate them. We need something like, an HPV status that we can do, where we can say, that's one of those and not one of those. So I think we need to get there. All right, so, stage, of course, is very important, but there are a lot of other things that make a difference. And the first thing that everybody always thinks of nowadays, of course, is, the molecular fingerprinting of lung cancers and what type of gene rearrangements or fusions or whatever that you have. And, this pie changes like every other week or something now. I would argue, I think that this pie and this research is kind of driven a little bit too much by profit. A lot of this is pharma research, and they're really driven by, I want to develop a drug. And there are probably things that we should be studying about this mutational pattern that aren't related to a drug necessarily, to understand things better. But I would say we shouldn't be just focused on genomics. There's other things. There's STAS, there's subtypes, there's PET avidity, and there's simply just biologic behavior. You so often we have prior CT scans, and it's so fascinating to look at what's happened over time. There's some cancers that are very aggressive about growing very rapidly, others that are very indolent. There's some that, grow to a pretty big size, and yet no sign of any mets. And then there's others that are pretty small and there's already mets. The behavior is different. And we actually can see a lot of that right in front of our eyes. We should be codifying that. We should be, I think, using that to help us, understand and approach this differently. So let's talk about the metastasis a little bit. So, it turns out that cancer cells can exist in a number of different states. So, we always think about the primary tumor, but, there's premalignant lesions. There are these things called perivascular niches, where there are cancer cells, but they're just sitting there. They're not doing anything. And then there are cancer cells that actually, even with early stage cancers, you can find them in the bone marrow, but it's another niche where it's just sitting there. It's not actually doing anything. Now, when we think of metastasis, we think of it getting into the bloodstream. So to get into the bloodstream, you have to have intravasation into the bloodstream to develop circulating tumor cells. So when does that happen? It turns out that happens probably in response to microenvironment stressors. There's a lot of research on this. The change in the microenvironment, probably influences this, but it's not fully understood. And how does it happen? The cells don't just kind of plop into the bloodstream. They have to undergo a epithelial to mesenchymal transformation. They have to change into a different phenotype of a cell. That's what most of the research points to. There's a little bit of research that says there's some epithelial cells that can get into the bloodstream through the basement membrane by some other changes in the cells without actually becoming a mesenchymal phenotype. But, for the most part, it's this epithelial to mesenchymal transformation. And there are a number of things that govern how that happens. So then when you have circulating tumor cells, what happens then? Well, to really become a metastasis, they have to get out of the circulation again. And it turns out that that doesn't really happen. So very few circulating tumor cells actually survive. Most of them just kind of die off and disappear. And another thing that's very interesting is that this different phenotype that is, this mesenchymal phenotype, the tumor cell actually, the epithelial phenotype proliferates. The mesenchymal phenotype actually doesn't proliferate. It seems to be an either or. You know, it has the ability to migrate, but it doesn't really proliferate much. So, you know, when cells undergo this opposite, you know, mesenchymal to epithelial transformation, they can get back out of the bloodstream and they can establish sites of distant. No, it isn't just a matter of getting into the bloodstream, because we know that different cancers have predilection for different, you know, particular areas for Mets. And there's a lot of research showing that there's a lot of stuff that happens in the microenvironment of those sites that is kind of like holding up a sign saying, hey, if you're a lung cancer cell looking for a place to set up shop, you know, here's a good place. We got it all set up for you. We don't fully understand how that happens. And there are these pre-metastatic niches where there's cancer cells. You can find cancer cells in the bone marrow and various tissues, but that aren't actually proliferating and becoming metastases. They're just sitting there. Why are they just sitting there? Don't really understand that completely. And there are dormant cells where there's a met, but it's not really doing anything. And there's something different about dormant cells and pre-metastatic niches that certainly is beyond my understanding, but people are looking at these differently. So why it shows up in certain sites, there's definitely a lot of preparation and cell signaling and things going on that we don't fully understand. When do dormant cells wake up? Also poorly defined, but they can sit there for years and then wake up. So a lot of things going on. It's a complicated process. So let's talk about the immune system a little bit. So the immune system obviously needs to recognize self, and it needs to recognize foreign tissues. And it also needs to have this ability to ramp up. You got a bacterial infection, you got to ramp up like crazy, but then when it's over, you got to wind back down so you don't have a lot of collateral damage. And there's actually a big component of the immune system that kind of monitors this and kind of makes sure that it's, you know, doing the right thing. So there's a lot to it. So for cancers, actually, it's true as well. So how do cancers evade? Well, you know, part of it is that the immune system just doesn't recognize it. Just says, you know, I'm not seeing this as foreign. But some of it is that the immune system recognizes this as foreign, but says, I'm not doing anything. I'm not being directed to kill that cancer cell. I'm not doing anything. So this was an interesting study, you know, looked very carefully at a bunch of different clones of metastatic cancer and did a lot of, you know, detailed analyses of microenvironment and, you know, changes that were going on in all of these different clones. And so, you know, some clones survived, some clones didn't. It was a fluid thing. They did this very detailed study looking at, you know, immune recognition and immune intervention. And in fact, they developed a model that could predict which clones were going to be successful and which ones were not going to be successful. The point of all of this is that it's complicated, it's fluid, it's not linear, but actually we can learn to understand this enough that we can make some predictions from it. So I think that there's a lot of sort of hope there that, you know, we need to look into these things and understand this better. So fluidity over time, you know, we need to really be thinking about this a lot. So EGFR inhibited cancers, you know, we treat them with a TKI, they respond beautifully. But then usually after about 18 months or something like that, they develop resistance and they start to grow again. So part of the resistance that you see is this red slice of the pie. These are adenocarcinomas that turn into small cell lung cancers. And then you treat with a small cell appropriate treatment and you treat that small cell. And then after a while, it grows again and you realize now I have an adenocarcinoma. To me, that's like saying your cat just turned into a dog and then turned back into a cat. But, I think we need to just think about it differently. We think about, there's probably another layer sort of underneath this adeno, squame, small cell thing that we need to recognize. And we're just seeing a particular manifestation of that looks like an adeno or a small cell, but there's probably a deeper layer there. And, if you look just sort of across the spectrum, we now treat a lot of patients with various treatments, and sometimes you see most of the Mets have responded and they're stable, and there's one that starts to grow or didn't respond, and we treat that one with local therapy. It's a rogue Met, you can call it, but and these things change over time. So we need to think about things in sort of a fluid way. So how do we move forward from here? Well, I think we need to be thinking in a number of different levels. I think that there's, basic anatomic TNM, and there's, squamous and adeno, and is this a ground glass, and, so forth. We can get a lot from looking at CT scans. Does this look like a local grower or an early spreader? There's things that we can learn from that. We need to be thinking about the molecular profile and looking at that, and what that tells us about things. We need to be thinking about the immune response and what is the microenvironment like, and immune response. I think we need to get a little bit more sophisticated in how we look at that, and what that means. And there's fluidity over time. There's emergence of resistance and discordant responses, as we just talked about. A lot of these things are actually interrelated. So, if we understand some of these are going to have impacts on the rest of it. But I think we need to be doing this kind of multi-level thinking to really, make progress in the future. Now, you might be saying, oh my God, this is just, my head is spinning and this is too complicated and so forth. But I think we're actually already doing a lot of this for lung cancer, but we're already doing it in a lot of ways. We just need to get more organized about how we're doing it, I think. So I would put to you that, we are always doing this. We are balancing multiple outcomes. We're thinking about short-term outcomes, competing health, long-term outcomes. We're thinking about the data on this, how well do I actually know what the long-term outcomes are here? How surely is this defined? How well does this apply for this patient? We're kind of weighing these different sort of nuances of the data that we have relative to that. And on top of it, we're thinking about other aspects of, how this is going to be for this patient. And then we're thinking about, how do I manage this, in a personal interaction way. And, we're weighing all of these things every day when we're talking to patients. We're doing this sort of complex, multi-layered thinking about stuff. I think we can get more organized about how we do with this with lung cancer as well. And we can do that. So I get the feeling you're all looking at me like this, how am I supposed to do this? So I want to leave you with a little bit of a, shining a light on a path of, how I think you can do this. Couple of tips. One is, we have all these mental constructs, but we got to recognize them for what they are. They can be helpful, but they also can be, barriers and hurt us. So, mental constructs are, usually based on an association, but they are not a proof of a mechanism. And we buy them as if they were proof of a mechanism and they were an absolute truth that is unassailable. Why do we do this? Well, there's lots of research on stuff that, that shows that, the way we are wired is that if you make an observation, but you tie that observation to a story, you can remember it. So if you say, it's really cold out this morning, and that's because I don't know, of something, the climate, crisis that is coming or, something else, then you can remember that much better than if you just make an observation alone. So we are wired that way. We have a natural tendency to do that. There's lots of psychological experiments that show that, if you tell somebody an observation, but at the same time you give them a reason for it, whether that reason is right or not, hypothesis, they will remember it better. So that's why we do this. But let's recognize that we do this. And I think dogma is actually pretty easy to recognize because you hear everybody saying the same thing. When you hear that, you got to step back and say, whoa, wait a minute. Do we really know that? Or are we just saying that? So, here are some mental constructs that, I think we all kind of carry with us a little bit. Lung cancer is due to smoking. It's aggressive. It's, once it's cell is there, it's going to go on and do its thing, and it's not going to be fluid or change or whatever, and spreads through lymphatics. And, a lot of this stuff, I've already kind of debunked it, by stuff that I've shown you. And yet, we're very prone to kind of these things. And I think we have to recognize them and try to not let them restrain how we think. I also think that we need to be careful observers. There are things that are in front of your nose. So, here's the model of the solar system as it, was at one point, where the Earth was in the center and everything revolved around the Earth. And there were really very complicated, diagrams of how things sort of rotated and moved so that, when you watched how they actually move across the sky, you could explain it with the Earth in the center. And, if you put more than one planet together, you come up with this really complex thing and so forth until, somebody like Galileo said, well, wait a minute, just put the sun in the center. It's pretty simple. You don't need all this complex stuff. It's pretty obvious once you just look at it differently. So there are observations that are right in front of us that, we need to, keep track of. Of course, this was heresy at the time, and it was, data and science sort of coming up against a religious belief, i.e. a dogma. So be careful of dogma. So this is an example. This was kind of back in the 2000s. There was an observation. People were saying, well, epidermal growth factor receptor mutations, if we inhibit that, might that be of some benefit? There was some laboratory data for that. Clinically, trials weren't showing any benefit. And yet there were some patients like this where 6 weeks later, it was dramatic, and there were some people, so Tom Lynch, that was our cancer center director for a while, was one of these people, but people that said, wait a minute, anecdotally, there are some people that are responding, even though when I'm doing a clinical trial on this, I don't see a signal. And they investigated this further. You had to, spend time, and people invested a lot to kind of look into this, but then realized that, well, there are EGFR mutations and we have ways of identifying them, and that, has an effect on whether they're going to respond or not. And there were clinical trials that later proved that this was the case. And of course, we have all sorts of other driver mutations now and treatments for that and so forth. But it started out with a spark of an observation. That's the point that, I want to leave you with there. So this was another study that, was a little bit later, but it was the IPASS study, looked at stage 4 adenocarcinoma and chemotherapy versus gefitinib, which is an EGFR inhibitor. And this was the overall survival, the progression-free survival curve. And, overall, it was not clear that this made a difference. But, the curves cross over. It's sort of a little bit odd. And it turns out that if you separate these curves, if you're EGFR mutated, gefitinib results in better survival. And if you're not mutated, then EGFR inhibition results in worse survival. So we need to not be looking at these as one disease, We need to look at these as different diseases in order to see the signal. When we look in, apples and oranges together, we may not see something that works for apples but doesn't work for oranges. So I think we need to be thinking about these things in order to see the signal. Another reason I would point to this is CAPTCHA. So CAPTCHA is, you're doing something on the computer or you a robot and click on the flower, whatever, that is because a human being can look at a one-off thing like that observation of the, 6-week dramatic response, can look at a one-off thing and say, gee, I think I can recognize something. I think I'm onto something. Computer can't do that. That's why we have this test all the time. We need to remember this. So let's talk a little bit about refinement and innovation. So refinement, you start out with a, intervention that is already there. You make incremental progress. You make it more efficient, more accurate, faster, whatever. A lot of benefit from that, no question about it. You need a lot of data to be able to do it. Reproducibility may be a bit of an issue. So AI is actually very kind of set up for this, to take things and it's an association, and you can kind of refine the association and you can make it faster and you can make it better, and it may be able to recognize sort of new patterns for how we make it better. But fundamentally, it's a refinement. It's not the innovation I was talking about where you recognize something, you say, well, wait a minute, why don't I put the sun at the center of the solar system? Why don't I do that? That ends up being a transformative thing. I don't think we're going to get that from AI. We're going to get that from things that we do that we recognize. We got to keep, doing that. And that's kind of a fundamental different thing. You start with an idea, but you got to do a lot of work. You got to do a pilot. You got to, look at this. You got to test it. You got to figure out, does my idea really hold up? Does it really work? But once you really say, I have figured out the underlying mechanism, not just an association, now we kind of know that this is going to be reproducible and it's going to apply, at least when that mechanism is at work. So an important thing. So, AI, medicine is really, here's an old saying, but, combining medical knowledge with, clinical judgment, and, it's what we do every day. Are we going to replace that with AI? I think we need to use AI to our advantage, but we shouldn't be thinking AI is going to solve all this for us. We have to stay engaged to make to have the insights and to do the right thing. Okay. All this stuff, as we're delving into new areas, a lot of uncertainty. We can actually manage uncertainty, and I think we need to learn to be comfortable managing uncertainty. And I'm going to take just an example that happened to have it, but was asked to give a talk about limited resection versus SBRT for slow-growing lung cancer, subcellular lung cancers, and it forced me to kind of break this down and think it through a little bit. There's a lot of uncertainty about this topic. Well, if you think about it, okay, well, we're all going to die someday. So you got this red curve, no question about that. And then there's a non-progressing GGN. It ain't never going to hurt you. Okay, that's good enough. But then there's maybe some slow progressing GGNs that might hurt you. Which is it? Got to figure that out. Okay, there are unrelated deaths. And there are deaths related to this GGN. Even if it's progressive, something else going to get me first, or is that going to get me? I got to figure that out. Okay. Problem is, you're here and my crystal ball is cracked. So I'm trying to make predictions way out there, and I'm way at the beginning. So that's the fundamental, I think, problem that we have. So to deal with this, let's make some assumptions. So let's assume that this is the GGN that's going to progress. I don't actually know that, but let's just assume. And let's assume that this GGN is the thing that's going to kill you. So now all of a sudden you've got an earlier death than unrelated, unrelated deaths are not, going to be the issue. And let's assume that you do an intervention and it's going to be successful, 100% success rate of that intervention. Okay, so now you have a treatment benefit. You're going to die of an unrelated death at some point in time, but you've taken out that early death from that lung cancer. The problem is that there's also a low risk that you're going to have a problem from the treatment. And, that's going to be a big deal. Maybe a low risk, but it's a big deal. So you got this difficult balance of how do I balance something that is kind of way off in the future and is a potential benefit and a big downside, but pretty low risk of that big downside. How do I balance that? That's also difficult. So, we got to figure this out. We got to figure this out. We got to balance this thing, so how do we do this? Well, let's assess the data and let's try to, wrap our arms around it. So, we've got this idea that we've got, mortality versus what is the chance it's going to progress? What is the chance it's going to cause death? And what is the chance of cure with treatment? So treatment-related mortality, these are the numbers that I get, actually. People tend to assume that SBRT is, could never hurt anybody. If you look in all the, NCDB and all the databases and so forth, it's about 1% at 90 days. Now, that's even when you try to take out the people that were, poor performance status and so forth. It's still not zero. Probably a little bit higher for lung cancer, for surgery than SBRT. I think that's true. But, it's not like you don't pay a price at all with SBRT. So what is the chance of progression with the GGN? We said it's about 30%, but progression to a fatal lung cancer? Okay, I'm not really sure, but, let's say 10%. I think it's less than that, but, let's assume that. Chance that that's going to be the cause of death, well, again, hard to estimate, but, let's put a 10% number on it, and I think GGNs tend to progress in a very linear kind of fashion, whereas unrelated deaths, people tend to kind of do okay for a while, and all of a sudden they start to, have more rapid decline. So that's another factor. One is linear, one is not linear that you got to kind of balance. What is the chance of cure? Well, maybe it's a little bit less with SBRT than with surgery. I think most of the data would point to that. So if we do the math, we end up saying, the benefit, the difference between surgery versus SBRT, that's pretty small. That's really not the issue here. That's not what we need to, be worrying about. The big issue is, do we do anything at all? What is the short-term risk of, lung cancer mortality, not lung cancer, treatment-related mortality versus, this long-term risk that this is the thing that's going to kill you. That's really what we've got to figure out. And the big problem with that is that there's a lot of uncertainty there, a lot of uncertainty. So you don't know what to do. You phone a friend. So this is Yoda's advice. And this would be what I would say as well. So I would say if you wait for a while, we've got data that GGNs are not, they have a pretty linear trajectory and they have a much, much decreased propensity for distant metastases. So if we wait to kind of see what that's doing, we can get a better sense of how fast is that progressing and how is this patient doing? Are they starting to develop more health-related issues? And you have a better sense of, how I can stack that deck, and I have a little bit more certainty about how to do that. So the point of this is that I think we can think things through that are difficult to decide and that have a lot of uncertainty, and yet we can think them through and we can kind of figure out what are going to be the real drivers of the decision and how do I affect those drivers of that decision? How do we, in the face of a lot of uncertainty, put some guidance on how we are making decisions. I think we can do these things, and I think we need to do these things a little bit more. So that's just another thing I think about how we move forward. Okay, critical thinking is important. Experience, once we find something that works, there's a famous experiment that you can do. People do the same thing over and over again. They don't actually test whether that's, the right way or, something else works. They just keep doing the same thing over and over again. The more they do the same thing over and over again, the more they become convinced that's the only way to do it. Maybe I'll skip over some of the scientific principle. You start with a hypothesis, and then you say, I'm going to test this hypothesis. I'm going to assume that there is a different explanation for it. And only if I can prove that all other possible explanations do not work, only then am I going to say that this works. In clinical medicine, we don't do that. We come up with a hypothesis and observation. We find one piece of data that supports that. And then we say, there we go. I've proven that this is the way it works. We don't say, well, wait a minute, maybe it's something else. Let me test something else. We don't do that. We mislead ourselves all the time. So I think I'll skip over that just to come to a conclusion. So I think we need to do this multi-level thinking. I think we can learn to do this. I think we already do a lot of this. And I think that, the way that I would get to it is, recognize thought constructs. Don't let them mislead you. Observe things that are in front of you. You got to develop those ideas. You got to, you can't just sort of take a hunch and take it to the bank. You got to, test it and figure it out. We can learn how to manage uncertainty. And, we need to keep thinking critically. But I think those are basically the things, if we do these things, and, that's sort of a general statement, but I think that's how we move forward in lung cancer as well. So I'll leave you with one last quote here from Enrico Fermi. Before I came to this lecture, I was confused. I'm still confused, but on a higher level. So I hope I've accomplished that.
Out of time. I think if you want to ask questions, you come down, but I really need to ask.
Okay.
I'm going to take the introducer's prerogative and ask one question. You had one little comment at the end about TNM, and the 9th edition is just out, and you are just lead author on the paper that's in Chest about how much more complicated it's gotten, but it's much better. And so with all of this information that we now have about tumors, individual tumors, where do you think the anatomic staging is going to go in the future? Will it stay that way, or will we have to adjust to include all of this other information that is now pretty readily available?
So I would say that, yes, we have to adjust, but, TNM describes anatomic extent of disease. And I don't think we should try to make TNM cover everything, but because we don't ask it to cover everything. We say TNM, but I look at a, T2N0 carcinoid totally different than I look at a T2N0 adenocarcinoma or small cell lung cancer. I look at those differently in somebody that has a, class 4 heart failure and ejection fraction of 15% than I look at somebody with class 1, heart failure and doing fine. So there are all sorts of different measures that we place on a lot of different things that we take into account when we're making decisions. And I think anatomic extent of a cancer is an important measure, but I don't think we should try to make every other thing fit into that. So mutational status, all these things, but I think we need to develop more of a structure for those things, because without the structure, without the recognition of the family of diseases and so forth, we don't see the signals. We're not able to do the research as well. If you think of prognosis from TNM, it's because we have a definition and we've been able to do a lot of studies that we feel like we know what that means. We need to develop those structures so that we can do those studies so that we can have a better understanding.
Thank you.
Okay.